Welcome to the Registry Insider. I'm Bill Seifarth, CEO and Executive Director for the National Registry of EMTs. And on today's episode, we're answering some commonly answered or asked questions, I should say, regarding the National Registry examination, including, the adaptive test and its nature, and a couple other questions related to it. So joining me today is Dr. Mike McEvoy. He's chair of the board of directors here at the National Registry of EMTs, and he and I, as well as several staff members, have been at several conferences over the last year or so and felt it would be a great opportunity to share with you, the listeners, a few of the questions that are frequently asked, and hopefully it'll be helpful to you. And if not to you, then others that may have those same questions. So, Mike, thanks for joining me again for another episode here.
Thanks. It's great to be here. Yeah. Definitely.
So obviously you spend a lot of time with us in the booth at conferences and or at presentations you hear, and you get a lot of questions. We get a lot of questions related to the test. So
sure.
What are some of the questions you hear that you've encountered recently?
Well, I think, the fundamental question that I hear all the time is I have completed a paramedic program, completed an EMT program or an EMR program, and every test I took, I get a score from 0 to 100. And so I'm trying to figure out, how does the registry exam work? Mm-hmm. Because I don't see I get a score from 0 to 100. And we talk about CAT exams or computer adaptive tests. Mm-hmm. And so I'd like to spend a little time just delving into that a little bit. So when we say it's a CAT exam, and so we have that at the EMR level, the AEMT level, and the paramedic level.
EMT.
EMT, not AEMT. Not AEMT.
Yeah, so AEMT is our only exam that is still linear and doesn't have the adaptive algorithm yet. We will likely be doing that in the next few years.
Yeah.
And I think, and I agree with you, that is a very common question that I get. And then we'll get into some other common ones. But, the beauty of an adaptive test is it's really precise, and it precisely measures someone's competency, especially around the cut score. By the cut score, we mean what's the passing standard for someone that is safe and effective or has the minimal competence to effectively function as a clinician in the field.
And that's what the whole test is trying through a series of questions to decide with probably a 95% confidence level, if you're a statistician out there, that you either have passed or you have failed.
Yes. Or I hate saying the word failed.
Well,
yet to pass, not yet passed.
You're not yet minimally competent.
Yes, that's correct. And that's really where I say the exam is very precise. It does it really well. It also does it very efficiently, in that a student doesn't have to sit there and answer 300 or 400 questions, but rather, for a paramedic, they answer a minimum of 110 questions, a max of 150. For advanced EMT, it's a linear or a fixed number. It's 135. For EMT, it's 70 to 120 items is the maximum number, and for EMR, it's 90 to 110 questions. When I say items, it's questions. Mm. So it can really precisely and quickly and efficiently measure someone's ability if they're competent or they're not yet competent. And that's, from one of the reasons that we do adaptive is for those reasons, but also it's more cost effective because it's expensive to securely administer the examination. And a lot of people, a similar question, very related, a lot of people that I hear come up to the booth and say, why are your exams so expensive? They're expensive because, one, there's a lot of cost that goes into developing them properly. I mean, we bring in panels of people. We have and multiple panels to help write them, to help review them, independently review them. Then we have staff that review them, make sure they're grammatically correct in the same style and format. And then we have to pre-test them on live exams where they don't count for or against. And then we bring in other panels to help set the standard as far as what the passing standard is for all the exams. So there's a lot of activities that happen. And the most expensive part on top of that is the actual administration of it. I mean, we have a vendor, it's Pearson VUE, who administers our examinations for us securely. And, we take our mission seriously as far as protecting the public and making sure that when, the public calls 911, they expect a competent paramedic to show up. Part of that starts with their education, and then we independently assess their competence. But to do that independent assessment, we want to make sure that it's secure, that it's fair, that it follows all the psychometric parameters and principles that are accepted. But that security is the most expensive part of it. So that's very expensive to do and to do right. And the fact that we use adaptive testing helps to keep the cost down a little bit so that it's not as expensive for the candidates who are taking the exam. So it's kind of a slight compromise, but still is a very precise way of measuring competence.
So you're taking an adaptive exam and you get a question, you answer the question, and you answer correctly. The idea is that the adaptive exam then is going to give you a little bit more difficult question, right?
Mm-hmm.
And you answer that correctly, it'll give you yet a little bit more difficult question. And you answer that incorrectly, then it'll give you a little bit easier question. And it keeps going back and forth like this. So people come out of the test sometimes and say, well, I got the absolute minimum number of questions, so that means I must have passed.
I must have passed or I bombed it, one of the two.
Exactly. Yeah. And so, but I don't think people realize that could mean that it came to a 95% certainty that you were not competent.
Yeah. Yeah.
Very quickly.
Yeah.
As opposed to dragging it on where you get the absolute maximum number of questions. Now, let me step back and compare that to a conventional linear exam. And we have a couple states that still use a state exam where they give you a set of items, a set of questions, and it's a fixed set. And those are all the questions that everybody takes that night when that exam is being given. How do you compare that?
There's several comparisons to it. One, the simplest of which is the precision of competency, and the exam development process through which we go to develop those items and develop the forms in the exam is far more complex with an adaptive nature, but the benefits are we have a more precise exam. Again, we have multiple panels reviewing the items, writing the items. We have independent panels representative across the country setting the standards. So the exam development cycle is very robust. And to my knowledge, none of the states that do their own exam have any of their examinations for EMS accredited. We do. We're independently accredited by the National Commission of Certifying Agencies, and our examinations are held to a very rigorous set of standards to ensure that the examinations are valid, reliable, psychometrically sound, legally defensible, and equally important, that they're fair. They're fair for the candidates who are taking the examination, as well as fair to others in the profession that are having an expectation that anyone who's entering our profession, they be competent. So the examination has to have all those attributes to it, and arguably examinations that don't follow that process, frankly, don't have those standards. So they're either not valid, not reliable, not sound in the psychometric perspective. Perhaps if challenged legally, they would not be able to defend it. And last, potentially, they are not fair. An emphasis on potentially, because I'm not sure specifically what lengths to some of the state level exams do go to have that. But the final thing as it relates to computer adaptive testing is security. You can have a great exam and follow all the steps, but if you're not ensuring that they're securely administered, then the exam is compromised. If an exam becomes compromised, the instrument they're using, that examination, is wasteless. It's pointless. We know of a couple other states who did have their own exam, and within a few weeks, the exam was online and compromised. So that's why we take the security of our examinations so important. And that's another difference between National Registry examinations and state developed and administered examinations. The security is real important. So I think those are the two key things.
Yeah.
The cost related to developing our examination, which is really a lot of what goes into the examination, but the the assurance that we have followed all the parameters and the standards for high stakes examination. And then the second thing is the security in terms of the administration examination. They're the two things I think that separate us from a state administrator exam.
And I would guess with a linear exam, if you're like, let's take the EMT, for example, you have to have a certain number of questions on that, a certain number of items on that exam that pertain to OB, a certain number that pertain to trauma. There's no opportunity for the person taking the exam to get an easier or a harder question if they answer one wrong. So on this night, this day, there's going to be 5 OB questions, and these are going to be the questions. And if you just don't happen to know the answers to those, well, too bad. You got those wrong.
Yeah.
And there's no opportunity to get an easier or harder one to test
your abilities,
your overall knowledge of that area.
Yeah, absolutely. And, if you were potentially weak, severely weak enough in a topic that it will bring down your overall score, which will then reflect on your overall pass rate. But on a linear exam, that may not be as much the case. I mean, certainly you'll miss potentially 3 questions, but again, that precision, that psychometric precision and ability to measure someone's competence is far more precise with adaptive tests than with linear. Now, that gets to a point. I mean, you brought up earlier, one of our exams is still linear, adaptive test. And the reason why it was adapted and has been adaptive for a while is we didn't have enough volume to turn it into adaptive. One of the things that's required is you need to have a high volume of candidates taking the examination so that we can confidently have enough statistics that can make sure that each of the items are enough items are in there, and each of the items have been exposed enough that we have data on them, so we know how well they perform. And that allows the algorithm, the adaptive algorithm, to run effectively.
And that's the AEMT
advanced EMT, yeah. And we're at a point right now where I think the National Registry in the next few years is able to entertain that, because our focus has been over the last few years fixing a lot of stuff, launching the ALS exam, this year launching the BLS exam, even though it's just really not a significant change.
Yeah.
And then going forward, I think we have the opportunity and capability of focusing on AEMT and making it linear.
Yeah. Now, I want to mention a couple things. When you talk about fair, one of the things I've seen in board meetings over the last 12 years is there is a periodic review of the exam by ethnicity. And to say that a person who is, for example, Hispanic will interpret a word differently than a person who is Caucasian. A person who is African American will interpret something differently. And so those questions are tossed out because the way that they're worded will sway somebody to pick a choice that's an incorrect choice. So there's a lot that goes into the whole fairness piece of it.
Yeah, and what you're touching base on, certainly you talked from a race perspective, but one of the things that we look at on our exams is to make sure they're absent of bias. So we don't want to have any unnecessary bias, and it's not necessarily with gender. It doesn't necessarily have to be with race. There's also other biases that we look at, and it's part of our exam development process and part of our review process. We don't want there to be any regional bias. I'll give you an example. One of the classic ones is what we refer to here on the East Coast are manhole covers, which go over drains, storm drains.
Yeah.
And there are parts of the country, I believe Alaska to be specific, that doesn't have them. So that's a regional bias wherein we refer to something with a term here that they didn't know or because they've never seen where they are. Remember, we write to a national standard, and that makes it difficult. But that's a great example, though, of something that has a bias, and we want to make sure that we avoid that in examination because we want there to be an equal opportunity for everyone. We want it to be a fair examination for everyone that doesn't introduce unnecessary information that's not measuring someone's ability. So we are very mindful about that to make sure that we don't have bias. In fact, we have to demonstrate that and show what we do to look for bias and to eliminate it and avoid it at all cost if possible. Is it perfect? No. But when we find it, we will, of course, not continue to use those questions. So yeah, as it relates to fairness, we are very mindful of bias, and we have to be under our standards for accreditation.
And that's changed questions over the years. I mean, you look at questions that you see today, and we all have unconscious biases that affect how we treat patients. And so when you read a question, educators oftentimes come to us and say, well, why didn't this question say what gender the person is? And the answer to that is it's not relevant.
Yeah.
And, to use the word homeless sets a certain unconscious bias. And so a lot of those things are gone from the way that we ask questions, so that they're fair in the way that they approach that.
And like I said, our mission is very simple. We want to make sure that only those who are competent are certified, period. And we don't want any extraneous stuff entering the equation to help us determine that. It's also why we love to use adaptive testing, because, as I said, it's more precise, more efficient. And we have a 95% confidence that person, once they pass it, yep, they're competent, they're good to go. And we also, if someone fails it, we're confident that they're not competent yet.
Yeah.
So that's why I think our examination is the way it is. It's designed to use an adaptive nature, and it also, like I said, I touched on a little bit. It's more cost effective to do adaptive than it is otherwise.
Okay.
What are some other questions you've been encountering?
So 3 other things I want to talk about briefly. The first is run out of time.
Yeah, ROOT, as we call it.
ROOT.
R-O-O-T.
R-O-O-T, run out of time. Yeah. And so talk a little bit about that, because we're in the process of modifying that a little bit.
Yeah. So a ROOT is essentially, like I said, it's a situation where a candidate who's taking the examination actually runs out of time. And the time parameters, which I wrote down here so I wouldn't mess them up, but EMR is 1 hour and 45 minutes to complete it. EMT is 2 hours, advanced EMT is 3 hours, and paramedic is 3 hours and 30 minutes. So if a candidate reaches that point and beyond, the examination turns off. If the algorithms have yet to get that 95% confidence interval, and or they have not reached the minimum numbers, the minimum numbers would be 90 for EMR, 70 for EMT, advanced EMT, it's 135, and paramedic is 110. If we haven't reached that minimum number and they've maxed out on time, or we haven't reached the 95% confidence yet and they've run out of time, they will, as in essence, fail the examination. It is not yet complete. We weren't able to assess the competence because the time was run out. And so that is very rarely. It is statistically more uncommon than common, but there are some people that will run out of time, literally running out of time on the examination, and the exam will shut down.
Mm-hmm. Now, if they have answered the minimum number of questions, then how is that decision made when the time limit comes?
Well, if they have run out of time and they've reached the minimum, then they're in a predicament where the algorithms, we don't have the 95% confidence interval that they're competent. So the examination will shut down at that point.
Okay.
So that is, remember, they have to have the minimum number. We have to get to that 95% confidence interval. And we 95% confidence. And thirdly, we have to make sure that they have reached the minimum number of items, which I think I'm repeating that one. But so the time will run out and it will shut down the examination.
Okay. So leads me to my next question that I hear often, and that is, we have changed the way that we report success or failure on the exam. And so now, instead of getting a domain level, this is what you get in cardiac, this is what you get in OB, et cetera, you get here's the passing score, here's your score. And it's an overall number, and it's not based on 100.
Correct.
So talk a little bit about that.
Yeah, we use what's called a scaled score. And a scaled score is very similar. If anyone has taken SATs or ACTs, they'll get a number like that. And as it relates to domain level feedback, we don't give that. We talked a little bit earlier about us having adaptive tests being more precise, more efficient. One of the drawbacks is we don't test someone in a lot of questions in some of the domains. For example, in operations, it is not uncommon that an EMR, potentially even an EMT, could just a handful of items or a little bit more than that on operations. Well, it's not fair to say someone's competent or not yet competent or below standards or yet to meet standards, whatever we called it, for a domain. So we test. Our examination is not designed to give domain level feedback. It's not designed to give feedback specific to a topic at all. It's designed to look at the entire construct of EMS and the whole practice analysis that relates to the task they're on it, and through the sampling of items that are on there across all of the domains, it will give them a series of questions. And if, like I said, if it's adaptive, if it gets it right, they'll give them a harder one. If it gets it wrong, if they get it wrong, they'll get an easier one. So our examination is designed to measure all of EMS as it relates to that level that they're testing for, and not to assess how good they are with cardiology versus medical or trauma or OBGYN or airway respiratory ventilation. It is designed to look at the entire EMS field and at the level at which they're testing, and they will have a percentage of questions from each of those domains, which, by the way, people can go to nremt.org to find out what those domains are.
The blueprint.
The blueprint, yep. Mm-hmm. Click on About the Examinations. You can scroll down to level you want to, and you can see what the breakdown of the questions are for each of the domains. But, as it pertains to the overall outcome of it, if a candidate is unsuccessful, they will get what is a scaled score, and there'll be a mark there as far as what the passing standard is. And since they're below that, it'll show them how far away they are from that mark. So they can use that and gauge as they progress through time to see how well they're performing or not performing on the subsequent attempts. If someone passes, again, this is not a competitive examination. It's not necessarily an exam that's designed to rank anyone. We'll just say you passed, congratulations. And we're not going to tell you the score, because all that we care about is you've met the minimum standard, period. That's it. We're not going to worry about how well they did or how well they didn't do. Well, if they didn't do well, then we'll tell them how far away they are. But how well they did, if they're at the score or above, we're not going to tell them, because, again, the exam is not designed to give that level of feedback.
Which is kind of what we say in med school. The guy that graduates at the bottom of his class is called
still doctor. And the medic who graduates last
is still a medic. So basically, someone who says, I need to know how or what it is that I should study, and we're not giving a domain level score report anymore. So where should they go?
I'd say, and literally, we were just at a conference last week, and I had this question probably at least a dozen times. I said, you need to go back to your education program.
Okay.
The education program's been with them. Over the last several months, if it's paramedic, it's a year or more. So they can give that level of feedback. And the candidate and the education program should know where their students potentially have some challenges and can help them with additional resources. Plus, there is a plethora of study resources that are out there that can help students target where their weaknesses are, where their strengths are. Just Google any, past EMT, past paramedic, paramedic test study guides, EMT study guides, and there's a lot of them that are out there. Strongly encourage them to do that. But first and foremost, go back to your education program. Have them help you to pinpoint where you need to perhaps have a little bit more focus. But the advice that I also give is, don't just focus on your quote-unquote areas of identified weakness. Make sure you go back and review everything, because the test is not going to be just on your areas of weakness. The second one is going to be on everything. Yeah. Again, the whole domain's related to EMS.
Yeah. So we're running out of time, but let me ask you one last question. So how many times can you take the test?
You can take a total of 6 times. After the third attempt, candidates have to get remedial training. And with that remedial training, they can go ahead and make sure that they are up to speed, and then they can have a 4th, 5th, and 6th attempt.
Okay, good.
So, Mike, thanks for joining me on this this topic of frequently asked questions. It is something, these are just a few of the most frequently asked questions that we encounter at the booth. So appreciate what you do for us. And thank you for joining us as well. And as always, stay safe. Thank you for joining us for this episode. If you wouldn't mind, please click the like and subscribe buttons, as well as the notifications so you can get notifications of upcoming episodes. Also, for the latest and greatest happenings of the National Registry, feel free to go to nremt.org. Thank you very much. And again, stay safe.